Today we will be talking about types and management of wounds. Coming to the wound classification system, it is classified on the basis of etiology: clean surgical, shearing or degloving, crush, blast, burn. In burn, you have thermal, electrical, chemical, radiation, mechanical. Then there is cold injury, avulsion or traction, low or high energy, and bite. Further, on the basis of depth, the wound is classified as epidermal, dermal, and full thickness. In dermal, you have superficial or deep. Okay. On the basis of contamination, it is classified on as clean, clean contaminated, contaminated, dirty, implant or non-implant. On the basis of complexity, they are further divided into simple, complex, and complicated. In complex, you have significant soft tissue loss. Then there is open fracture or joint. Okay, there is visceral involvement. In complicated wounds, you have infection, you have necrosis, you have hematoma, you have gangrene, you have compartment syndrome. Okay. Then on the basis of chronicity, it is further divided into vascular ulcers, pressure ulcers, diabetic ulcers. In vascular ulcers, they are venous or they may be arterial. See, now what you are seeing is the US Center for Disease Prevention and Control surgical wound classification. Okay, so you have class 1 wound. In class 1, it is also termed as clean wound. Okay, so what comes under that? Uninfected operative wounds. Okay, if no inflammation is encountered. Okay, respiratory, alimentary, genital or uninfected, urinary tracts if you are not entering. Okay, primary enclosed and if necessary drained using a closed system. Okay, then there comes class 2 wounds. Class 2 wounds are clean contaminated. The clean contaminated are respiratory, alimentary, genital or urinary tracts are entered under controlled conditions. Okay, and without unusual contamination, no evidence of infection or major break-in technique is encountered. Okay. Then class 3 is termed as contaminated. In contaminated, you have open, fresh, accidental wounds, operations where there are major breaks in sterile technique. Okay, they come under class 3 contaminated. Okay, if there is any spillage, in GI tract, incision in which there is acute non-purulent inflammation when it is encountered. Okay. Then we come to class 4, the last type, which is also called as dirty wound. Okay, they are old traumatic wounds. Okay, with retained devitalized tissues and those involving existing clinical infection or perforated vessel. Now coming to the clean wound. Clean wound, there is no viscous is open. For example, breast surgery, if you are doing a thyroid surgery, CABG, okay, knee replacement surgeries, uncomplicated inguinal hernia surgeries, they all come under clean wound. Now, percentage of surgical site infection with antibiotic prophylaxis is 1 to 2%, and without antibiotic prophylaxis is also 1 to 2%. No or minimal role of prophylaxis in clean wound except when an implant or mesh has been placed. Now coming to clean contaminated wound. Clean contaminated wound are when there is viscous has been opened, when there is minimal spillage. Okay, when we enter the GI or genitourinary system, but there is no inflammation, that would classify as clean contaminated wound. Example: elective cholecystectomy, urinary stone removal when there is no UTI. Okay, LSCS, then laparoscopic abdominal hysterectomy. If we are performing this, they comes under clean contaminated wound. With antibiotic prophylaxis, it is 3% rate of surgical site infection. Okay, and without antibiotic prophylaxis, there is 6 to 9% rate of surgical site infection. Now coming to the contaminated wound, open viscous with spillage or inflammatory diseases. Okay, when we enter the GI or genitourinary system, when non-purulent inflammation is present. For example, emergency cholecystectomy if we are performing, emergency appendectomy if we are performing, if we are doing enterotomy. Okay, we are operating in a bowel, we are opening the bowel and operating a case of intestinal obstruction. because the bowel is not prepared, so hence that becomes contaminated. Okay. So the risk of surgical site infection with antibiotic prophylaxis is 6%, and without antibiotic prophylaxis is 13 to 20%. And antibiotics should be continued as well in as in post-operative period. So next comes to dirty wound. Dirty wound, what is dirty wound? In dirty wound we have pass or perforation or incision through an abscess. All abscesses are dirty. Okay. If peritonitis is present or any fecal contamination is present, any neglected traumatic wound for more than 6 hours, because risk of infection increases exponentially if left for more than 6 hours. Coming to risk of surgical site infection in dirty wound with antibiotic is 7%, and without antibiotic prophylaxis is 40%, and is continued post-operatively. In elective OT, we always include clean cases first, so that we can avoid this contamination. So coming to acute wounds. Okay. So what are acute wounds? They are bites. Okay. Most bites involve puncture wound or avulsions. Wounds over the metacarpophalangeal joint should be treated as a human bite following a punch to the mouth until proven otherwise. Okay. Now coming to degloving injury. Degloving is the avulsion of skin, okay, and subcutaneous fat from the underlying fascia, muscle or bone. A degloving injury may be open or closed. Closed degloving injuries result from shearing force, which may occur with motor vehicle collisions. Okay, they all come under degloving injuries. Okay, so there might be disruption of vascular, and lymphatic vessels, resulting in characteristic hemolymphatic collection between the facial planes called a Morel-Levy lesion. Okay. So this is a figure you can see degloving injury of the right little and ring finger. You can see. Okay. Now see, this is the mechanism of injury for Morel-Levy's, okay, in lesions. Okay. See, in this you can see the layers of the skin. First the skin, subcutaneous fat, superficial fascia, deep fascia, the muscle, then bone. Okay. So what is happening? This is a cross-sectional image where you can see that all the fascias can be seen, and leading to, after the injury, ultimately it's leading to the formation of hemolymphatic collection in the potential space. Okay. Why? Because of disruption of hemolymphatic collection is there, but because of disruption of the vessels, okay, underlying vessels. Okay. Now coming to acute wounds, acute compartment syndrome. Okay, acute compartment syndrome occurs when there is increased interstitial pressure within a closed osteophyseal compartment, which results in microvascular compromise. Okay, it is a surgical emergency as delayed treatment may lead to irreversible muscle ischemia and significant long-term morbidity. It is characterized by pain out of proportion to the injury, okay, particularly with passive movement of the affected compartment muscles. Paresthesia is another early sign. Absent pulses are uncommon and suggests the possibility of vascular injury. Now coming to acute compartment syndrome. Compartment syndrome is generally a clinical diagnosis. Okay. It can be difficult to diagnose in the presence of impaired consciousness in children and in patients with regional nerve blocks. Monitoring intercompartmental pressures, ICPs, can sometimes help us to guide in the management. A pressure of less than equal to 30 mm of mercury between the diastolic pressure and ICP has been recommended as the threshold for fasciotomy. So, if an ICP pressure is less than or equal to 30 mm of mercury, the diastolic pressure and the ICP, a pressure between these has been recommended for, that you can go for fasciotomy. Fasciotomy involves incising the skin and deep fascia with long axial incisions. Okay, what we do in fasciotomy, we cut open the deep fascia to release the pressure. So you can see a figure where fasciotomy of a leg is being performed. Now coming to acute wounds. Acute wounds are further classified. Okay, they are necrotizing fasciitis. Okay, in this there is severe, rapidly progressing infection of the soft tissue and fascia associated with significant morbidity and mortality. The infection is commonly polymicrobial but monomicrobial presentation with Streptococcus pyogenes. Like group A Streptococcus is also frequent. Other organisms which include their Staphylococcus aureus, E. coli, Pseudomonas, Clostridium, bacteroids. These there is a usual history of trauma or surgery with wound contamination. Yeah. Diabetes mellitus is the most common comorbidity. So the treatment consists of intravenous antibiotics, urgent radical surgical debridement we have to do at that time. Okay. So this is the management of necrotizing fasciitis. See the signs and symptoms of necrotizing fasciitis. They are divided into local and systemic. The local signs are unusual pain, erythema, edema, warm, crepitus, blisters, bullae, grayish drainage, means diswater pass, then fixed staining, necrosis, gangrene, and systemic there may be what type of symptoms like fever, tachycardia, tachypnea, shock, coagulopathy, multi-organ failure. Okay. Now coming to the chronic wounds, these wounds fail to progress through the normal stages of wound healing in a timely manner. They are often characterized by a prolonged inflammatory phase and persistent infections. Chronic wounds can be categorized into vascular ulcers, diabetic ulcers, and pressure ulcers. Coming to chronic wounds they are leg ulcers. An ulcer can be defined as a break in epithelial continuity. A prolonged inflammatory phase leads to overgrowth of granulation tissue and attempts to heal by scarring, leaving a fibrotic margin. Okay. Necrotic tissue, often at the ulcer center, is called as slough. Okay. So, what is a Marjolin's ulcer? Okay. A chronic ulcer that is unresponsive to the dressing and simple treatment should be biopsied to rule out neoplastic change. A squamous cell carcinoma, known as Marjolin's ulcer, being the most common in this scenario. So, effective treatment of any leg ulcer depends on treating the underlying cause, and diagnosis is therefore vital. Arterial and venous circulation should be assessed. So, coming to the etiology of leg ulcers, they are vascular, like venous, arterial, or they may be mixed. Trauma, bites, self-inflicted burns, infection, bacterial, fungal, mycobacterial, syphilis. And there may be metabolic disorders like diabetes mellitus, gout, calciphylaxis, autoimmune disorders. There may be vasculitis, systemic sclerosis, rheumatoid arthritis. Then there may be neoplastic, where we see squamous cell carcinoma and basal cell carcinoma. Now coming to the chronic wounds. Chronic wounds. They are pressure ulcers. Pressure ulcers occur over a bony prominence or under a medical or other device. Pressure injuries should be regarded as preventable. There is a higher incidence in those who are severely ill and those who have impaired mobility or those with a significant loss of sensation. Common sites for pressure injuries and ulcers are ischium, greater trochanter, sacrum, heel, malleolus, occiput. These are the areas where they are more prone for bed sores, and they are the areas where the pressure areas means they where the maximum pressure of the body in these points. Coming to chronic wounds, prevention starts with assessing risk using a validated score to support clinical judgment, such as Braden scale, Waterloo score, or Norton risk assessment scale. Okay. Patients at risk of developing pressure injuries should have a skin assessment, regular repositioning every 2 to 4 hours, and use of pressure redistributing devices are appropriate. See, this is a pressure ulcer. Uh, Coming to wound management, assess the patient using advanced trauma ATLS guidelines, advanced trauma life support principles to first identify and treat life threatening and conditions. Okay, assess the size, site, geometry, nature of wounds, look for signs of contamination, infection, swelling, and pulsatile bleeding. Deformities may suggest underlying fractures or dislocations. Okay. Now Before pulsation, ensure that patient has adequate analgesia or local anesthetic block when possible. It is important to assess motor and sensory function before any local anesthesia. So these are the principles of wound management. Clinical judgment is crucial in managing wounds. Some general principles of wound management are antibiotic prophylaxis is needed for clean contaminated and dirty wounds. It also may be used in clean wounds when there is high risk of infection or when sequelae of infection are potentially disastrous. Tetanus prophylaxis should be given based on the type of wound and immunization status. So this is the principle of wound management. You have to first prepare. In preparation, what you have to do is you have to give antibiotic prophylaxis, tetanus prophylaxis, adequate analgesia or anesthesia, wound irrigation you have to give. Okay. In wound, there should be early debridement and irrigation, exploration, repair of structures, hemostasis. Okay. Then there is closure. This closure may be skin closure without tension. Consider reconstruction options, suture choice, consider drains, optimal dressings, and then you follow up the patient. Follow up, there is removal of sutures or splints, physiotherapy, the monitoring for complications, scar management. So risk factors for increased risk of wound infection. They are malnutrition, metabolic diseases like diabetes, uremia, jaundice, then immunosuppression like cancer, AIDS, steroid, chemotherapy patient, radiotherapy receiving patients, okay, colonization and translocation in GI tract, poor perfusion, systemic shock and local ischemia, foreign body material, poor surgical technique, dead space or hematoma. Now coming to prevention of wound infection, first is hand washing. Okay. Most important factor of hand hygiene. Okay, the minimum duration of hand wash should be 2 minutes with soap and water, or we can do a alcohol rub, hand rub. Okay. Then prophylactic antibiotics, ideal time is 30 minutes to 1 hour before surgery. If it's a prolonged surgery, then we can repeat antibiotics after 4 hours. Part preparation. Patient should take a bath with antiseptic solution a night before surgery. Hair removal, best way to remove hair is clipping of hair using a hair clipper done just before the surgery. Okay. Cleaning of the part which is to be operated, done in with chlorhexidine plus alcohol or done with povidone iodine. Abdominal surgery, male patient irrespective of surgery, nipples to mid thigh. Female patient for intramammary creases to mid thigh. Okay. Now coming to abdomen, when we are cleaning the abdomen, we will clean the midline first, then we will go laterally, then we discard the swab. Okay. But when cleaning thigh, their perineum is dirty area and we go to the dirty area in last, so it's lateral to medial. Okay. Limb, we clean one joint up. Okay. Proper dissection and adequate hemostasis. Then we have to prevent hyperglycemia, prevent hypothermia. There is a high level of incidence that both perioperative avoidance of hypothermia and use of supplement oxygen during recovery significantly reduces the rate of SSI. Okay. The OT temperature has to be kept in a range of 18 to 22 degrees Celsius. Relative humidity is 50 to 60%. Minimum 4 fresh air changes is in theatre in 1 hour is required. Management of wound infection. Acute wound management consists of cleansing, exploration and diagnosis, debridement, repair of structure, replacement of lost tissues when indicated, skin cover if required, skin closure without tension. All of the above should be done with careful tissue handling and meticulous technique. Now coming to chronic wound management. Leg ulcer unresponsive to dressing and simple treatments should be biopsied. To rule out neoplastic changes, meshed skin graft can use when surgical treatment is done. Pressure sores. Prevention is the better treatment. Surgical management follows the same course of acute wound management along with preoperative adequate debridement and vacuum assisted closure. Large skin flaps with muscles can be used as grafts in these cases.